Hi, I'm Dr. Bill White. I'm a general dentist, and the only difference is I've been doing nothing but orthodontics for about the last over 45 years, and I do some temporomandibular joint work along with that, but almost completely orthodontics. And I am a member of the American Orthodontic Society, and this is an organization of general and pediatric dentists that are devoted to study of orthodontics, and we recommend that any dentist that's interested in orthodontics and would like to join our organization, come in and study. You can learn orthodontics. Now, it is you're able to do that. We have a good journal. We also have a board certification, and if you pass these boards of the American Orthodontic Society, you can do orthodontics, so there won't be any question about it. I want to discuss a favorite subject of mine, and it's palatal separation. And I've shown this skull to start off with. Actually, we wanted to kind of break this down. You can't actually get these skulls anymore, but I got this one years ago, and it'll show you a lot of things about palatal separation here. We found that just putting a palatal separator across the palate back in here, where you had the little separating device, push it on the second or the bicuspids, maybe in the molars, that it was very difficult to separate the palate out here in the anterior part of the palate. So the nasal septum, there's a lot more bone there than there is. And I learned that years ago that you could come in with a sliding arch wire in this portion of the mouth and pack spring in between your brackets on these upper centrals, and just pack all the spring you can get in here. That you've got a tremendous amount of pressure on that, and you need a fairly good size arch wire so it doesn't just poke out, it can bolt out like that. It's a fairly stiff arch wire. It'll stay straight, and you'll get the force right in between these teeth, and it'll separate in the anterior suture up here. And we've been able to separate people in their 30s and a few of them in their 40s. And some that we couldn't separate, we were able to just move the bone structure apart and kind of stretch the bone out in that area. But some older people, it would not separate. The suture wouldn't come loose. So I'm gonna go through some other things here to show you in doing this. Like when you separate it, I never know where the nasal septum is going to go. I'm sure it doesn't split itself, but probably breaks off one way or the other, and the septum goes one way and the space goes the other way, so you probably get a little increase of airway on the opposite side of the septum. Now when you look at it from the palatal side, this is just the skull turned around. I'm taking a picture through here. Here's usually where your separation takes place, in the palate, and it probably branches off somewhere up in the nasal septum. But you give people more airway if you can separate the palate, and if you can keep the roots of the teeth parallel. You don't want to just push these roots out, or push the teeth out and have them tilt back in, because you'll actually reduce the airway in doing that. But if you keep the roots parallel. In other words, keep the surface of the tooth pretty much level. As it goes out, the root will go with the tooth, and this will increase the airway up in this area back in here. And if you've got somebody that's got a lot of allergies, and if you make the hole big enough, or you make it a lot bigger, it's harder for it to close too as a result of the allergies. So let me show you again the bone structure that separates is really this right along in here, and this is not a great deal of bone in your separator. Normally we band these teeth right in here and the 6-year molar, and usually put a bar on the second molar. It'd be better if it was banded too, really. And then we start cranking this apart, and usually the cranking takes place somewhere along in here where you're separating, and so the pressure's exerted from this point, and it's very difficult to get enough pressure at this area where your palatal separator actually is, the separating machine, and where the major part of the bone structure is out in this area. So we have gone to putting a lot of spring between the two centrals on a sliding arch wire, and we were able to separate the suture on people up in their 30s, and once in a while somebody in their 40s. You could do this. Now I went to Donald Timms, who is an Englishman who they came up with a palatal separator years ago, and he was at a meeting in New York, and I met him and talked to him a while, and I asked him how late he was able to separate palates, and he said, oh, about 17, somewhere maybe 18, but that was the limit. It wouldn't go apart there. I wasn't very polite to him. I said thank you and just walked away. But I had already separated people in their 30s, and I didn't think I should tell him how to do this, but I really probably should have. He might have appreciated it. I don't know, he might have been insulted or something. But anyway, if you'll do that and put a lot of pressure in the front, you can separate palates a lot further down the line than you normally could. I'm going to show you some cases later on how we do that. This erase these things after I've drawn them. And now this is the other side, and these are of course the turbinates, and we got space in between there. And these are things that swell up, and get puffed up from allergies, and also the turbinates kind of enlarge on one side and shrink on the other side, and kind of alternate the air flowing back and forth. So you really can help a person with a breathing problem if you can get in there and separate the palate. So I have really pushed that in lectures for years and years. I have done many palatal separations, and to my knowledge I've never had one of them that started bleeding, except that I had a kid one time that started bleeding, but he had nosebleeds anyway before he ever separated his palate. So don't think the palatal separator creates a nasal bleeding problem. Some people might think it would. Now, as you separate the palate, you see, you're going to change all the bone structure up in here. This is even your glenoid fossa, where here's your ear, and here's where the condyle fits, and the eminence and stuff like that. It's going to change the bone structure all around over the head, and it'll have to adjust to that and adapt to it, and this bone structure will change in a period of time if you keep keep it in that position. And we've advanced mandibles and stuff like that, and over a long period of time, the mandible will change shape, and the whole mechanism up there will alter according to the different function that it's being used in. Alright, here's a palatal separator appliance that we use, and this isn't a glorified one. We actually made all of our palatal separators in the office. I had two fine ladies there that worked with me, a couple of them nearly over 40 years, and one of them still there. Tricia Smith is still with us, and so she's made many of these palatal separators over the years. Now, when you separate in there, of course, you have to stop back here on your separator. You don't try to run into it with this, but you have a sliding arch wire that slips through the brackets here, and then you just pack as much spring as you can get in between here, which puts a really good pressure on this area to separate right there. Now this down the bottom is our Big Daddy expansion arch, which we're not going to get into this right now. But anyway, it was on the typodon. I was showing this. Here is the palatal separator. Now the people can make them a lot neater than this nowadays with laser welding and stuff like that, but I like to band all the teeth. Now some people come in here and say, oh no, we'll just put a bar back in here, and we'll just put a bar alongside this. We'll have one band on the 6-year molars. That's not what you really want. You want to put the bands on all the bicuspids and the 6-year molar, and if you could, it'd be good to put them on second molars too, so that as you go apart with these teeth, we're going to push this apart, and these bands are cemented on really good, and as you separate them, they will tilt a little bit. The tooth will tilt out buccally to some extent. In other words, the lingual cusp will get a little higher than the buccal cusp if it tilts much. But then when you do that, the occlusion hits on the lingual cusp of the teeth, and the tooth itself, just from the mechanical pressure back here, tends to want to parallel or go out, bring the roots out, forcing this out. And you also put a real stress on the appliance that you've got here. So it's trying to actually bring the roots out too, because you're bending the bands and stuff like that. So you're better off to cement all the bands in. I know these guys that go along with bonding on and a bunch of stuff like that, and just putting the one molar banded. I don't like that. I want to carry these roots out buccally as well as the crowns as I go separate. And we may separate some of them like that. I mean, we may have a quarter of an inch or more of separation down through here. As you go apart, then the central teeth will come back together, and you can bring these together. Now, I have taken some cases where we separated something like that, and then we'd have a pretty good space, and then we start to close the space in the front, and this will bring the case back. In other words, you may bring the anterior part of the face back, and if you've got so much protruding out, well, you can separate them to the side, and you'll bring the anterior portion back. because of your extra space you've got in here. That's just something you might want to remember. So if you've got somebody that's too doggone protrusive, and you can go in and separate their palate, give them more airway and broaden everything out, you will actually bring the profile in some as you do that also. Now this is just a little close-up of that spring. Your wire's got to be free to slide in here, and so when you can bend this spring on somebody and then have it sticking out here like that, and now just keep spinning it until you pack it. You'll have to catch it with a director and slide it in here as you go along and keep it pressed over here. And actually you can have these springs just almost contacting each other on an open coil spring. Instead of being open like something like that, it'll just be actually closed like that, you see. Now that puts a lot of force moving the teeth apart like that. The same thing in there. Now let's go ahead and look at the palatal separator. If you make these yourself, be sure and set them up, where you engage this hole right here and you push it backwards with a key and you go back into the mouth, and I have the key and tie it to a couple of rubber bands so the patient won't push it back there and drop it down their throat, you see. And so it opens by turning. In other words, that deal would be round like this, and then have a hole through here and a hole through here. Now each quarter turn is a quarter of a millimeter, and if you come in from the front part of the mouth, you want to have one of them kind of headed up like this, and you push the deal in and you shove this over, and that'll be coming out in this fashion, you see. And now I let people open it once a day like that, so that's a quarter of a millimeter a day. And when this deal gets back there, then this one will be up, and you can engage it, come over, and then keep turning this little jack screw back here, separating this. Now this jack screw is sticking out on each side of this deal, and as you come way back with them, your jack screw will probably be screwed down to something of this nature right here. Now I have there's a secret of putting these bands on the mouth. For a while we would put them on there and hope that we got them correctly and we cemented them, but now we don't ever cement them the first day. Of course, you build in the palatal separator, we put the bands on the teeth, and we take an impression of the teeth, and then we come in there and build your palatal separator on these bands, and then you have to take them off and split them off there and take them out. And now you go back to the mouth. They're never going to be exactly parallel. I have a tooth here and a tooth over here that's perfectly parallel. You'll have one of them headed a little one direction, another one some other direction, and you've got to slip them on there however you can, the best you can. Now, so we put them on and then force them up in position and leave them there for at least a week, sometimes 10 days or more. And they'll come back in, and those teeth will have adjusted to those palatal separated bands, and the palatal separator will go all the way up in the mouth real good at that point. So that's a little trick. Don't cement them the first day. poke them in the mouth or put them in over the teeth as good as you can. Show them how to take their thumbs and press them up in position. And if they come loose or anything, just push them back up again. I've never had anybody just lose one of them in between that week or 10 days that we had them wear this. They have to use a lot of water picks and stuff because food's going to get under them and they're going to have a odor to them. So do that. Now that's just for the steel, stainless steel. It's soldered with electrical arc welding. I've never done any of that laser welding, but it's really neat. But I don't like this single deal. I want bands on everything in there, really. So I like to have the band structure on all the teeth. Now, let me go back here to start off with the case. I'm going to show this palatal separator, and I think my little red dot has disappeared, so I'll have to go back and get it established. Now, the case that I'm showing here I did a long time ago, and this little girl had a cleft palate when she was young. It wasn't out over her lips, but they had to go in and do some work on her palate, and so she's got a really messed up dental arch in there. The upper is just much smaller than the lower, and one of the upper molars is gone, so we've got several things going on here. And we had to just start out and kind of wait until she got a 6-year molar, which probably was a second molar, came in the mouth, and then we could actually start the case. And I think it's at this 1975 is when we actually started. And this was a tooth that was just coming in the mouth, right in here. We'll show you this a little bit better on some of the x-rays when you come in. Down below she had missing second deciduous molars and had a little space maintainer, which is not a big deal. I don't care all that much about them. But anyway, that was her lower model. This is her cephalometric, and I can't really read the date on this, but I think it was around 1970. No idea. I think it was 73, something like that. Now, this is well, this looks like this one was 72, and the 6-year molar is gone here, and the 12-year molar is coming in, so we'll have to wait until it gets in pretty good to attach it to actually start the orthodontic work in the palatal separator. So here we are in 1973, I believe, and we're still not quite ready to get started on this case. Now this is 75, and we obviously have started here because I've got the palatal separator in and showing it on the panoramic x-ray. Now these were the older panoramic x-rays, and you had to jump over, but I liked them. A lot of times we'd trim the teeth out and put them together, and you'd have a real nice panoramic showing the relationship of the molars and everything in the panoramics. Now this was 1976, and we're pretty well on the way with this case now. Now after we separated the palate, I thought I was going to have to hold it apart. If I remember correctly, I had to use 2 palatal separators to get it apart far enough to have the upper teeth way out over the lower teeth, then brought the lower teeth out, kind of expanded them and lined them up on it. And after I had actually done the palatal separation, I actually touched her in the palate, and there was just a little area in there about the size of a pencil eraser. Now I could feel one, and the other one I couldn't feel, but I could feel this one right here. And so she's very conscious of this. But when the palate was separated, this didn't separate or split or do anything. It just stayed about the same. And I didn't notice it till I got through with the case. So anyway, as we separate the palate frequently, you're going to have your lingual cusps come down a little bit, and they start hitting on the other cusps, and your bites will open. Now this case, the young lady lost one of her bands here, and so we had to do that. But the palatal separator's in there now, and it's going to town, and it has created an open bite situation. So the molars contact, but they don't up here, and so she's going to have a little more vertical dimension. So sometimes to keep them from separating, we will bond acrylic on these teeth right in here so that they chew on those blocks in here, these acrylic blocks, and that puts a lot of force on these to intrude these molar teeth, the bicuspids and everything here. So that brings us down where we don't have these sticking out the breeze. And so you really want them to be down over the lower anteriors too. Okay, this is back before we changed completely the brackets. We went over from 1974 or 5 to about 19. It took about 4 years, before we really got this. It was 1907 or 8, before we really got all the cases going in brackets. So we had a lot of banded cases to treat. Now this was her upper palate when I saw the young lady. This says 75, but it was like back, it may have been when I took these models or something, but actually I saw her back in, I think it's 72 or in that neighborhood. And let's see. Now we went in and put a palatal separator in there, and I cranked this thing apart. It was about like that. We cranked it apart that much and moved these teeth out. And we also brought this out in front. And without knowing, there was a defect in the palate right here. If I just put my finger over it, I could have felt it, But I didn't know it till I finished the case. I might have been afraid to go in here and try to separate the palate because that was a bony defect there in the tissue. So anyway, it's taken care of now. Now on the bottom it was fine, and had a tooth loss, and so she's bringing the 6-year molar, holding it in that position. Now, when we separated it and then pulled these centrals together, they kind of lean this way, see. But they will actually carry the root structure over like that. If you wanted to, you could come in here and put some down bends and arch wire stuff, and it would move them over there too. Now, you young folks that have never done a fully banded case, I don't know, it might be good to have everybody do a banded or two case. Then you'd really appreciate orthodontics. It was really tough to go in there and band all these cases. You had to separate everything in the mouth, and then you had to put a band on one tooth, a band on the other tooth, and you had 2 layers of cement under the band and 1 layer in the crevice of the band, right like that. So it was a pain doing this. And putting the bands on, we put them on with a thumb pressure mostly. And my thumbs got so callous, they were just like a cardboard almost, you know, pressing bands into the mouth like that. Anyway, it carried out. We got this going good, and we separated this and held it open. And as she matured, the people would bring her up, and they would not have any problem showing them this and what was taking place in here. Now, at one point, we had, of course, brackets on everything, and those laterals were too small to fill the space. We held a space open with just a kind of an expanding 036 arch wire, made like a kind of a W or M, and pushing that apart. Now I took my little finger on my left hand and pushed it in between the 2 teeth on this child's models, and it almost touched the 2 teeth. Then after we separated the palate, I put my little finger in there, and you can see the difference in between the molar teeth and the other teeth. And back in here we have something here, and then we'll come over on this side. Now this is just some more pictures after we had it all separated, everything done. We're just tying it off and going here, lining all the teeth up, get them well interdigitated and everything, going to town. And let me see if I've got some finishing stuff on this young lady. Now here we needed a little midline elastic, and it helped out a lot. Now the areas coming along fairly well in some aspects. So anyway, this is what happened. We took her out of the bands and everything, and closed the space all at once, and we got her pretty well closed together. Now this is 1978, and this is held up, and most all these palatal separators, you get them breathing correctly and the teeth put in there correctly, most of them will stay with you. It's possible they wouldn't. Now this is a case where the anterior part is fine, and back in the back it's even a little class 3-ish, you see. And that's the one we had problems with there. So you can see the palate up here, and then you see the palate we ended up with. Okay, that pretty well carries that young lady out, and we spent about 34 to 35 minutes on this particular case. So I'm gonna come in here and stop this deal, and this will be the first phase of palatal separation. So I'm gonna stop it here.